Welcome and good afternoon. My name is Chris Rhodes. I am the Chief Executive Officer at the American Indian Cancer Foundation, and it is my pleasure to moderate this webinar. I want to thank you for joining, and we have some excellent presenters, and we've had a lot of interest in this topic. We appreciate your time today. So the purpose of today's webinar is to explore the opportunities and barriers related to delivering quality colorectal cancer screening and follow-up care in healthcare settings serving American Indian and Alaska Native communities. We will provide an overview of the data on colorectal cancer incidence, mortality, and screening rates in American Indian and Alaska Native populations. We'll learn about the American Cancer Society and the NCCRT, that's the National Colorectal Cancer Roundtable's work to address this issue, and hear from two American Indian and Alaska Native serving healthcare systems about their innovative approaches to increasing colorectal cancer screening. So after I provide a brief overview of the key data, we will hear from Dr. Laura Makaroff, the Senior Director of Cancer Control and Intervention at the American Cancer Society, who will walk us through the ACS and NCCRT's past and current work on this issue. We'll then hear from Richard Musow, Director of Community Health Prevention Programs with Great Plains Tribal Chairman's Health Board, and Jessica Deaton, the Care Manager at the Oklahoma City Indian Clinic, who will share how their organizations are increasing colorectal cancer screening among the communities they serve. So before we get started, I'd like to share a few housekeeping items. So we're recording today's webinar. The replay and speaker slides will be shared with you all in a few days. Please feel free to share with your colleagues that were not able to join us today. And also, because of the large number of participants, all participants are muted on today's webinar. So having said that, we still want to make sure you get what you need out of the webinar. We encourage you to ask questions by submitting them through the webinar Q&A function, and you'll find that in the lower right-hand part of your screen. We will have time for questions and answers after the presentation, and we'll answer as many as we can. We'll also be emailing around responses to any questions we don't have time to get to. And feel free to email us specific questions afterwards. Finally, we are always trying to improve our webinars, so we're asking for your help in evaluating today's webinar. So you'll be receiving an email with the survey link. If you could please help us out with taking a few minutes to provide feedback, we'd really appreciate it. So with that, I'd like to begin by sharing a brief overview of the data. American Indian and Alaska Native populations experience significant disparities in the burden of cancer incidence and mortality. Cancer is the #1 cause of death for American Indian women and the #2 cause of death for our men. When we look at colorectal cancer specifically, it is the #3 cause of cancer death for women and the #2 cause of cancer death for men. It's also important to note that, advancing here, it's important to note that we see that there's variability in mortality rates in different regions. Here we see colorectal cancer mortality rates are higher for American Indian and Alaska Natives than non-Hispanic whites within each region in nearly all of the regions of the country. So it's interesting to see this variation because you can see in the non-Hispanic white population there's not a lot of change from region to region, but in American Indian communities, you do see that a high deal of variation. Also, looking at the data, over the past 2 decades, there's been substantial progress in reducing the colorectal cancer mortality rate among whites, with clear progress seen in the red trend lines on both of these charts. So the chart on the left are males, and the chart on the right is females. Again, the red line is the non-Hispanic white population, and with the green line being the American Indian Alaska Native trend, which is going in the opposite direction. We have work to do. When we look at CRC screening among the Indian Health Service user population, according to GIPRA rates, we are seeing improvements in colorectal cancer screening among this population. You see in 2013, the rate was at 35% and has increased to 39.6% in 2016. Rates are still far below the Healthy People 2020 goal of 70.5%, and of course, below the 80% by 2018 screening goal that we've all been working towards. As we've seen with the mortality rates, we also see distinct patterns in American Indian Alaska Native screening rates among the 12 geographic areas defined by the Indian Health Service, which serves approximately 2.2 million individuals. And these are just a few of the disparities wait, slow down. I'm getting ahead of myself. So the colorectal cancer screening rates also range geographically from less than 30% in the Phoenix area and to just over 30% across the Alaska region, and you can see there's a great deal of variation in the screening rates. And of course, these are just a few of the disparities that American Indian and Alaska Native populations experience. We see higher death rates among American Indian and Alaska Natives in rural areas. We see an advanced stage of disease at diagnosis, and the age of onset often occurs before the age of 50. We see a high burden of cancer risk factors, and of course, American Indian and Alaska Native communities experience significant community and system-level barriers, and the graphic on the slide details out what some of the challenges are that are facing our communities when we talk about colorectal cancer. However, while we face many challenges in addressing these disparities, we want to acknowledge that there's so much work underway to improve colorectal cancer screening and health outcomes in American Indian communities. These pictures in this slide feature some of the great work that our team at the American Indian Cancer Foundation has had underway, led by Ann Wolozek and Joy Rivera, and also the campaign that's been happening in Alaska. We know there are many more out there, and today I'm excited to hear from Dr. Makaroff, who will share about the ACS and NCCRT's work to address this issue, and then we will get to hear from Richard and Jessica about their work.
Great. Thanks so much, Chris. It's great to be with you all today. We're really happy to be here and talk a little bit about some of the work that ACS has been doing to address disparity in colorectal cancer in American Indian and Alaska Native populations. I am relatively new here to ACS, so some of this work was before my time, but I'm really happy to get to be a part of it now. I joined here earlier this year in April, and I'm the Senior Director of Cancer Control Intervention, and I get to be a part of a grant program that we have here, and we've recently expanded to do some work with American Indian, Alaska Native serving organizations, which I'll tell you about today. So first, backing up to the part that I didn't get to be a part of, it was before my time here at ACS, but that many of you, I'm guessing, were a part of, and we really appreciate it. So back in April of 2016, the American Cancer Society and the NCCRT, that's the National Colorectal Cancer Roundtable, hosted a one-day meeting in Traverse City, Michigan. This meeting was a pre-meeting to a CDC summit on cancer in American Indian and Alaska Native communities. It started the following day, so it was really great timing. There were 30 participants from the CDC, from IHS, and from several other American Indian, Alaska Native serving organizations that participated. The meeting attendees outlined barriers and brainstormed about solutions and began to work on drafting the framework for change to help guide our future work together. Since then, we recently finalized a meeting report that's available and posted on the NCCRT website. I won't spend a lot of time going into the details of that today, but I'll just encourage you to go to the web link here, and you can read the report in its entirety there. The report summarizes the meeting presentations and the discussions. It also includes an introductory section that talks about key incidence and mortality trends, as well as colon cancer screening data. The report also includes the framework for change that I mentioned that the meeting participants began working on. And that looks like this. This is just a snapshot of what the framework looks like. You can find the full tool in the meeting report at that website. So this framework really lays out a plan of both some goals, some priority tactics, the barriers, and then potential community of solutions and the roles of those communities of solutions for these 4 strategic drivers of patients, providers, systems, and policy. So again, this is just a snapshot to show you what it looks like. We encourage you to take a look at the report and look at closer at this framework for change to learn more. And this really was a collaborative effort. The meeting participants began sharing input during the meeting and then shared additional input over several phases of feedback over the last year and a half or so. One part of the post-meeting efforts is that here at ACS, we have recently expanded our Change Grant program to have some projects funded in American Indian, Alaska Native communities. So before I share specifically about those projects, which are relatively new also, I just wanted to share a little bit about some background about the Change program overall. So CHANGE is an acronym that stands for Community Health Advocates Implementing Nationwide Grants for Empowerment and Equity. And what this really means is that this is a community-based initiative that supports cancer prevention, screening, and early detection in underserved and high-risk communities. The program started in 2011 and has had funding from various outside donors and has awarded over 500 grants to various community-based partners since 2011. Most of those grants have gone to community health centers and other safety net organizations. Of those 500 grants, 252 projects since 2011 have focused on colorectal cancer screening. The others have focused on breast cancer screening, cervical cancer screening, and we've had a few focused on HPV vaccination. Collectively, all of those projects have contributed to almost 3 million evidence-based interventions and 800,000 cancer screenings. There's been about $38 million that have been invested into the program by corporate partners. So as part of the post-meeting efforts, we were able to expand the CHANGE program to American Indian, Alaska Native communities. So through a competitive application process earlier this spring and summer, 5 organizations received grant awards to implement evidence-based interventions to increase colorectal cancer screening rates and also to improve systems of care so that all patients have access to high-quality screening, including follow-up of any abnormal non-colonoscopy exams and navigation to treatment if needed. The projects are really focused on implementing patient and provider reminders, doing other systems change and changing policies, including the use of standing orders, as well as increasing patient outreach, awareness, and education about all of the available screening options. So these are the partners that have received grant awards for this year. So we have just started the 2-year project periods. The project started this summer and will go through into 2019. So we have projects in Alaska, Arizona, California, Michigan, and Minnesota that you see listed here, and we're really excited about working with these organizations and learning more about their communities and their work. So each partner reported their baseline screening rates as part of their application process, as well as setting targets for year 1 and year 2. So that's what you see listed here, the 5 different organizations, their baseline screening rates, as well as their targets in year 1 and year 2. Collectively, the partners are working towards a 10% increase over baseline in year 1 and an almost 20% increase over baseline in year 2. We have just started the projects, like I said. They just kicked off in the end of June, July, and then one into August. So we're really just at the very beginning phases of this work. We have seen some initial progress. So in this first quarter of work, collectively, the 5 organizations have contributed to 700 screening exams, about 1,700 evidence-based interventions, which includes things like patient education, both group education and one-on-one education, patient reminders, provider reminders, and other provider assessment and feedback interventions, as well as some clinic policies and protocols. In addition to the cancer screenings that were done, we know that there were 10 abnormal or positive stool-based tests, which were followed up by colonoscopies, and then 7 colonoscopies with adenomas were detected, were done. And of that, we've seen 1 cancer diagnosis so far, and that's across all 5 of the projects. So we're really pleased and excited about this early work and know that there's much work to continue to do. A little closer look at some of the early successes and what some of these projects are working on. So this is what our grantees have shared with us, that in Alaska, they've hired a panel manager, and they've reached already almost a quarter of their population with client reminders and have helped reduce out-of-pocket expenses for a good portion of their population as well. Of course, Alaska has some unique geographic barriers. This project is in Barrow, Alaska, so there's some unique geographic challenges with how screenings are completed and where people live in relation to the bigger city. In Arizona, they've done some training with their health staff, as well as developing some promotional materials. They've been using our ACS resources to help create an implementation framework. And then they also conducted a survey of attendees who came to an annual health conference in the community, and that to get some feedback and better idea of the perspective of the community members about colon cancer screening. In California, they've also hired a panel manager and are working on kind of population outreach. They're using QI tools like process mapping to help inform their improvement activities. They're also going back through all of the positive fit tests in 2017 as they're developing new clinic policies and protocols, going back through to look to make sure that all positive fit tests were followed up with colonoscopy, which is really great and important work. And we know that timely completion of colonoscopy after a positive fit test is really, really important. In Michigan, they're using some ACS materials in their exam rooms to help improve patient education and raise awareness around different options for colon cancer screening tests. They've also done some data sharing and reporting of screening rates with their providers. And in Minnesota, they've hired a health manager already, and also used process mapping to help inform their improvement activities, and they're working on sending out client reminders to their eligible population. So in addition to these early successes that we've heard about in the first quarter of these projects, we've also heard about some identified needs. So several of the grantees have requested training, especially provider-focused training. We're in the process of working with them to identify some opportunities for that. And then one grantee is in need of some screening equipment. These projects are 2 years in length, like I was saying, so we really are just beginning. We have plans in the works to support the provider and team education in the near term, and are working on a longer-term strategy to support continued capacity building for the organizations as well as for the community at large and support sustainability. We have local ACS field staff that are working directly with these partners as practice facilitators and QI coaches to support their ongoing improvement activities and systems change. So we're really impressed by the dedication and passion of the project teams and the early successes, and are excited to keep learning more and supporting their work. And so before I end, I just want to say a big thank you to our partners who may be on the call with us, and we appreciate all of the hard work. We'll have more to share as the projects continue on. And with that, I'll pass it on to Richard to tell us about their work in the Great Plains. Thank you.
Thank you so much, Laura. As it was kind of introduced a little bit earlier, my name is Richard Musso. I'm an enrolled member of the Oglala Sioux Tribe. I oversee our Community Health Department prevention programs, which encompasses our Great Plains Colorectal Cancer Screening Initiative program here at the Great Plains Tribal Chairman's Health Board. So the program is actually CDC funded. We are in year 3 of our 5-year cycle. Just to give you a little bit of background on our organization, our mission is to provide quality public health support and healthcare advocacy to the tribal nations of the Great Plains by utilizing effective and culturally credible approaches. And our statement of purpose is our organization was established to provide our tribal nations in our region with a formal representative board as a means of communicating and participating with the Great Plains Area Indian Health Service and other health and human service entities and organizations on health matters. Our screening initiative works with a cooperative agreement with CDC. Our goal is to increase colorectal cancer screening rates within our 17 tribal communities and 1 service area in our 4-state region. Our 4-state region encompasses South Dakota, North Dakota, Nebraska, and Iowa. As we kind of know statistically in our region, Great Plains American Indian men and women have the highest and second highest cancer incidence rate among all AIAN population groups. And this is just a map of our coverage area. As you can see, it's quite extensive, and that's why the work is so important and a lot of the facilities that we work with. As you can notice, it's quite a large region. For us that are in the Rapid City area, which is on the western central part of South Dakota, to get to a place like Sac and Fox near Des Moines is about a 13-hour drive. Now, if we were to go all the way from Trenton to Sac and Fox, it would be at least a 16 to 18-hour drive. So just to put it kind of in that context, it's a very large region to cover. Our screening initiative works with, as I mentioned earlier, the Great Plains Area Indian Health Service. It's located in Aberdeen, South Dakota, and it works in conjunction with 19 other facilities. And is also, some of those facilities are tribally managed, and they provide health care to approximately 122,000 Native Americans and American Indians located in the region that I had talked about. The area IHS also provides health services to approximately 6,000 Native Americans who are not counted in the user population. And this is just a list of the facilities that we work with in our region. Just to give you a little bit of background, statistical data, I know Chris kind of mentioned a little bit of what the 2016 GIPRA rates look like, but before our program started, our screening rate in our region was 27%, which is quite low compared to a lot of other national standards. So it gives you a good context of when we're shooting for goals of 80% by 2018 of how much effort, how much work we really have to try to do to accomplish a lot of these goals, as well as the Healthy People 2020 goal of over 70,000, or 70%, sorry. And so one thing with the CDC funding is they really focus on evidence-based interventions, and that's why we see our framework and purpose in a lot of the work that we do is incorporating these into the work that we do with each facility. So those 4 evidence-based interventions that are recommended are provider assessment and feedback, provider reminders, client reminders, reducing structure barriers. I'll go over each one of these so that way there's a good idea of kind of what each one of these are, as well as some of the efforts that we've been doing to accomplish these evidence-based interventions. So there's also CRC supporting strategies that I'll go over that ties into a lot of these evidence-based interventions, and they incorporate utilizing things like small media, patient navigation, professional development and training, community clinical linkages, and health informatics. So take, for instance, small media. It's also known as patient education materials that are used to inform and educate people about cancer screening and motivate them to seek information, talk to a doctor, or make an appointment to get screened. Small media can be either mailed, emailed, used through different social media outlets to talk to specific audiences. And it's also recommended to use social media as well as other forms of media when really reaching those audiences, and those include radio, TV, newspaper, and billboards. A huge piece into a lot of the work that we do is patient navigation. Patient navigation is really crucial to the work that we do with, especially when we work with so many different facilities. So we actually have 3 patient navigators in our program, and those consist of Gina Thompson, Eugene Gallego, and our new staff member, Lindsay Huffman. So all 3 of them are really working with all of our facilities and making differences at the patient, community, and staff level. So take, for instance, working at the patient level, a lot of the work is done to incorporate cultural considerations, financial barriers, referrals, appointments, and education on preparation for screening. At the staff level, it's utilized to collaborate with staff to share insights into the characteristics of the population served, including potential language or cultural barriers or other barriers as well. So it really allows us to also build their capacity and their education when it works with one-on-one education and group education with individuals to increase their knowledge to encourage cancer screening. And then also at the community level, we do different things to promote screening at different events and activities and related webinars. And sometimes it also incorporates things like educational classes, like we do CRC 101, Flu and Fit webinars. So we've been able to really push a lot of those efforts, as well as increase fit in our region. We've really been able in the past 2 years to get most of the facilities to utilize fit. And then, of course, a huge piece of that is also to partner with other entities that might be either locally, regionally, or nationally. Another huge piece into that supporting strategy is professional development and training. So through this, we can optimize quality, as I mentioned, of increasing fit tests, but also selecting those appropriate tests in those areas. A lot of our facilities don't necessarily have the ability to do colonoscopies or sigmoidoscopies. Only a couple of our facilities do. So we try to find ways to increase that so that there can be better standards, as well as trying to achieve the gold standard when possible. Another supporting strategy that we really utilize is community clinical linkage. And this is done through different things, incorporating assessment evaluation, community engagement, individual and community education, skill building, and promotion. And that really becomes crucial in a lot of the work that we do in the region that we serve. Take, for instance, in my tribal community that's close by, there's only one facility for basically the area the size of Rhode Island. So because of that, by linking into all these different communities, which technically we have 9, it really allows more flexibility for the clinic to be able to be more accessible and more and for clients to know a little bit more about the services and what can be offered. And then one of our last supporting strategies, of course, is our health informatics. You know, as I kind of mentioned, this really ties in closely with our provider reminder system and client reminders. So for us in our region, we utilize a lot of the electronic health record as well as the resource and patient management system, also known as RPMS and iCare. So being able to utilize these 3 different interfaces really allows us to reach our populations through provider reminders and client reminders. And by having that coordination between the 3 and using them to their fullest capacity really allows us to notify patients as well as to really tap into what data there is as far as who's accessing and who's being screened. So I'm going to go over, after the last 2 years, we've seen some some successes in the sense of our cancer screening rates have increased from the initial 27% to 33.4%. That's a 6.4% increase, or 20 to 25% increase from baseline. And with that, that's basically an increase of 1,000 to 1,500 people that have been able to be screened for colorectal cancer in our region. So a lot of these strategies have been very effective in those approaches. I know I kind of just showed some different images and some of the different tools that we utilize, but ultimately it really takes a team effort in order to work with so many different facilities over 4 state lines. So it's a really comprehensive team approach, but these were just some different things that we utilized to really assist us in increasing our screening rate. So hopefully that was helpful and gave you some insight into some of the work that we're doing in our region, and we really appreciate you being on the call and learning more about approaches into increasing colorectal cancer screening. And I'm going to pass it on over to Jessica.
Hi, my name is Jessica Deaton. I'm one of the nurse managers at the Oklahoma City Indian Clinic, and I also head our Colorectal Cancer Quality Improvement Committee. Oklahoma City Indian Clinic was founded in 1969 by a group of volunteer physicians that saw patients for approximately 5 hours a week. The clinic was officially incorporated in 1974 in downtown Oklahoma City. Due to the location of the original clinic, the providers and nursing staff were also some of the first responders to provide care after the 1995 Murrah Federal Building bombing. Due to the continuous growth, the clinic was relocated to an area that allowed for expansion. Currently, the Oklahoma City Indian Clinic is operating out of 2 buildings and is in the process of developing a 3rd building. We serve members from federally recognized tribes that have their CDIB cards. Most of the patients come from the Oklahoma City area, but we do have some located throughout our state. Our patient population comes from over 220 different tribes and results in approximately 20,000 individuals who consider us to be their medical home. Of these 20,000 individuals, approximately 3,400 of them are in our screening population. This graph shows our screening rates over the past 10 years. As you can see, in 2007, our screening rate was only about 15%. We finished our last screening year at 64%, which shows an almost 50% increase in our screening rate. While we didn't meet our goal of 70% for 2017, We know that the efforts we're putting forth will continue to increase our screening rates so that we can accomplish 80% of patients screened by 2018. I know these process maps are difficult to read, but the one on the left shows what our process map was in 2015 when we initiated our partnership with the American Cancer Society. This graph on the right shows our most recent process map. Our processes have continued to evolve and improve as we continue to put in efforts to reevaluate and expand our screening. Identified barriers. Over the past 2 years, as our process map has expanded, we have also been able to identify our key barriers that inhibit patients' abilities to complete screening. The first of these barriers is transportation. A large percentage of our population is in a low socioeconomic status and does not have their own transportation. This leaves them relying on friends and family for transportation, and it becomes particularly difficult when patients have a positive FIT kit or choose to forego the FIT kit and complete a colonoscopy. Our closest Indian Health Center hospital that can perform the colonoscopy is approximately an hour and a half away, and they must make 2 visits, once for their consult visit and a second visit for their procedure visit. It's very difficult for our patients to be able to get to and from these appointments. The second barrier is financial. This barrier ties into the transportation barrier, as most patients' financial situation does not allow for them to purchase stamps to send back their FIT kit in the mail, and also makes difficulties for them to get to our clinic and turn them in person. Education is also a major barrier for our patients. Due to a lower literacy rate, it's much more important for us to gear our education efforts at a level that our patients not only understand, but also see the importance of completing screening. Lastly, which is possibly one of our biggest barriers, is with insurance status. All of our registration staff is cross-trained in screening for insurance eligibility, along with 2 benefit coordinators. The majority of our patients rely on Indian Health Services for their medical care, which means they don't often carry private insurance. While we can accommodate them with completing FIT kits in our clinic, we cannot send them out locally for colonoscopies if the FIT kit comes back positive. The uninsured patients have to make the trip to an Indian hospital, which is located about an hour and a half away, so the colonoscopies can be completed at no cost. As you can see, the above barriers listed make this very difficult. The next few slides will show some of our evidence-based interventions that we've implemented here at the clinic. If our patients have not returned their FIT kit 2 weeks after distribution, they're mailed a reminder postcard. If they haven't returned their FIT kit 1 week after distribution, they're given a reminder phone call explaining the importance of returning their FIT kit. If the FIT kit's returned positive, they're mailed out a notification letter that their FIT kit was positive, along with a handout from the American Cancer Society on what to expect with a colonoscopy. The clinic puts out a quarterly magazine that is mailed to all of our clinic patients, and we make every effort to include an article about CRC screening in each publication. We've also, for the past 2 years, provided incentives for completing FIT kits at our health fairs. Any FIT kits that are distributed at our women's health fair that are returned within 2 weeks were entered in to win a free night stay at a local hotel downtown, and this has encouraged and increased our returns from our health fairs. This slide also shows some of the evidence-based interventions that we've done. Since developing our CRC quality improvement team, we initially conducted monthly meetings, but have now decreased this to quarterly meetings to discuss new evidence-based interventions and ideas to increase screening efforts. This is made up of our Chief Quality Officer, our epidemiologist, along with me and our Director of Nursing. Our appointment titles are modified to reflect that the patient is also due for CRC screening as an extra reminder that they need to complete it. Staff education is also incorporated by not only bringing in representatives from the American Cancer Society and from the NCCRT, but we also publish monthly education passed around to our staff members. A nursing care protocol is available to allow all nursing staff to distribute and order labs for FIT kits, which helps to streamline the screening process. The past 2 years, the clinic has participated in National Wear Blue Day and Blue Star ribbons were distributed to all staff. This previous year, we set up a staff photo booth and took a staff photo, which helped to get staff participation in increasing awareness. Not only do we host clinic competitions with our nursing staff, but we also host them with our providers. The nurse that distributes the most fit kits within the year will win a free ticket for our local Stroll and Colon 5K race. The providers compete on the proportion of fit kits that were returned versus distributed. FluFit is also utilized at our clinic, and we've been using it for 3 years to encourage patients to do their fit kit screening when they come in to get their flu shots. And this has also worked with pharmacy distributing FluFit or fit kits to our flu patients. The Public Health Department has a community health representative that offers transportation 1 to 2 times a month to our local Indian hospital. They are able to provide them with transportation to their initial visit for their consult, but they cannot provide them with transportation to their actual colonoscopy appointment. We've partnered with the American Cancer Society, which has increased our knowledge and outreach efforts and led us to also participate in the NCCRT. In 2016, the clinic signed the pledge for 80% by 2018 and also submitted an application to join the NCCRT. This application was accepted, and we are now official members of the NCCRT. Strategies to increase our screening rates. Our colorectal cancer committee, or quality improvement committee, has implemented a variety of strategies to increase our screening rates. The most notable of these has been interdepartmental collaboration. We noticed that we had quite a few patients that were due for screening and utilizing our pharmacy but hadn't been seen by our medical department. We worked with the pharmacy department to allow a pop-up notification on these individuals so that when the pharmacy is distributing their medications, they also receive a fit kit with instructions on how to complete it. This has increased our screening rates by 3% in a 2-month period and by 5% in a 3-month period. Other departments that are distributing fit kits include our optometry, public health, mammogram ban, and registration is distributing them to the new patients over the age of 50 so that they can return them for their first appointment. The Public Health Department reorganized their department to include an oncology case manager that completes all the referrals for our oncology patients. This not only expedites the referrals, but it also eliminates confusion on who is responsible for the referral and ultimately streamlines the process. With this, Public Health is utilizing a cancer registry to account for and track all of our cancer patients. Future planning includes applying for grant opportunities, initiating and developing a support group, and moving consult visits to be housed here at the clinic instead of having our patients have to go outside for the visit. We have also discussed the pooping on demand and an on-demand CHR that's available full-time for transport locally and to the Indian hospitals. If we're to receive grant funding in the future, we would like to utilize it to provide all patients with return postage to mail back their fit kits, mail out anniversary reminders the month that they are due to complete their fit kits, and have a biannual education night with speakers for patients' education. The photo on the right came from our CRC photo booth this past March. The results of our colorectal cancer screening are shown in this slide. Our positive fit kit return rate is down to 4% from 17% the previous year. We attribute this to more widespread screening, which led to repeated screenings the next year. This can also be attributed to patients completing colonoscopies after their initial positive fit kit and not requiring another fit kit for 10 years. Approximately 10% of our cancer patients have colorectal cancer, and as you can see, the majority of these are males. Despite our patient population growing by approximately 120 patients a month, we are continuing to increase clinic-wide CRC screening. The graph above shows the colorectal cancer screening rates for Oklahoma versus the United States in 2014, specifically with our American Indian population. And thank you for letting me present this information to you today. I'm going to hand it off to Chris.
Wow, how exciting. So Laura, first of all, thanks for the update on the new ACS Change Grants that are happening in 5 communities across the nation. That is really exciting news. And Richard, of course, your examples of support provided by you and your team across multiple tribal communities in the 4 states of the Great Plains region is impressive. And Jessica, thank you for sharing how your health system at Oklahoma City Indian Health Clinic have increased CRC rates in substantial ways by implementing multiple strategies. We'd like to take some time for questions now. We have until the top of the hour, so we'll try to get through as many as possible. If you have a question, please submit it in the chat box down in the lower right-hand portion of the screen. I do have some that have been entered along the way, and I will start going through them and forward them, ask our speakers to respond. So the first question came in from Mark Bramblett, and he wanted to know why are screening rates decreasing in the non-native population, and how can we learn from that information and make it work in American Indian communities? I think I can answer that one. How about that? What we're seeing with decreasing screening rates in the non-Hispanic white population, or we're seeing decreasing CRC rates, is really the increase in CRC screening rates. And as we increase screening rates in our native populations, we expect to see decreasing CRC mortality. I will start out with that, and I'm going to hand it off to to Laura. Laura, do you want to add to that answer?
Sure, yeah, that's great. That's a great question. Thanks for that. And yeah, I would say the same thing, Chris. Agree that the decline that we're seeing in the colorectal cancer rates is largely attributed to the increase in screening over the last 30 years, which is really why we're so focused on increasing high-quality screening in populations that are not yet seeing the same progress.
Thank you. The next question comes from Dr. Situ Bora, and the question is, how are the screening rates defined earlier in the presentation, I think, or how to define it within the clinic? Again, Laura, can I ask you to respond to that question as well?
Sure. Yep, so I think earlier in the presentation there were a couple of different screening rates displayed. One is the GIPRA screening measure, which is how IHS defines it, and that screening measure is defined as the numerator is the patients who have had any colorectal cancer screening, which is defined as any of the following. So a stool-based test, a fecal occult blood test, or a FIT test during the reporting period. So usually GIPRA, I think, is a calendar year. So a guaiac-based test or a FIT test during the calendar year, a flexible sigmoidoscopy in the past 5 years, or a colonoscopy in the past 10 years. That's the numerator. And the denominator is the eligible patient population, which is patients age 50 through 75. And then the BRFSS screening rate is similar and includes patients age 50 to 75 who are up to date with colorectal cancer screening, meaning an FOBT, so guaiac-based or FIT test within a year, sigmoidoscopy within 5 years, with FOBT within 3 years, or a colonoscopy within 10 years. So the sigmoidoscopy, I think, includes sigmoidoscopy by itself within every 5 years, I think is how that is defined. So that's the BRFSS screening rate.
Great, thank you. Hector Burgos reported today. Hector is a he is an endoscopist. And he had 6 colonoscopies scheduled at an IHS facility today. Unfortunately, they were all no-shows, and he's wondering what else to do. Richard, can I get you to respond to Hector?
Yes, I definitely can, and that's a great point and I guess comments that he's making. And Hector is really a huge community champion and works with the Oglala Sioux tribe and for that Pine Ridge Indian Hospital. And so I really I'm glad he kind of commented and mentioned some of the challenges that, you know, as I was mentioning, of, you know, with a region so large, is almost like the size of Rhode Island, of some of the challenges that you have with scheduling, and at the same token, so I think access could be an issue, but I think also the information and education given about a colonoscopy and some of the different things pre-op wise. So that's why I talk about the importance of especially having, you know, the one-on-one education and group education developed, and how important that is for people at a lot of different levels, especially your public health nurses or your community health workers or community health representatives in our region. Those CHRs be really educated and really give people that opportunity, as well as work with the CHRs really closely, so that maybe they can offer some assistance or find solutions around some of those transportation challenges. So I find a lot of it usually has to do with access and the information and education around that. So I think improving those 2 areas would definitely help increase the appointees and increasing those completions. So hopefully that's helpful.
Thank you, Richard.
Thank you.
There are a lot of questions coming in. We have about 5 minutes left. Here's a question for Richard or Jessica. I'm wondering if you have explored utilizing the IHS National Supply Service Center as a source for purchasing FIT kits, or some other centralized site where FIT kits can be purchased at a lower price for clinics.
Jessica, do you want to take a shot at that? And then I can answer if need be in our region.
So I am actually not sure if we're utilizing them currently or not. Our lab director is in charge of ordering the FIT kits, but that is something I'm going to look into in case we're not utilizing them.
Thank you, Richard.
And I was going to speak, this is Richard, for our region. We have looked into that, and especially working with so many different facilities, we've done a lot of education on the importance with it. One of the challenges that we saw with one of our states, Nebraska, they're pushing some of the guaiac testing and different things, and so I think some of the different testing, you know, it's really important to educate, but also kind of know some of the differences. So even when we have opportunities to have people kind of present about the differences in those products, really is also important, as well as the cost impact. But we do recommend that, and also encourage finding those cost-solving solutions. And hopefully we will get at a certain point where all the facilities will be able to maybe go in on purchasing in those huge lump sums.
Thank you. Jennifer Antis had a question or a comment about that. I think it's pretty common in Indian country, where it's a small health center with only one physician, and looking for grants and funding to initiate programs. Maybe, who wants to take that on? It is a common issue faced by many of our clinics. Okay. Oh, go ahead, Richard.
Sorry. I guess I was going to say, yeah, it's really important to understand some of those different challenges, especially when it comes to resources and some of those barriers. For us, you know, we found it really crucial to offer subawards to each one of the clinics that we work with. But sometimes there's always challenges too with applying for grants and some of those different things. So I think it really depends on facility and kind of the area and region you're in. But if anything else, I really recommend to work, with those healthcare systems or with outside groups like take, for instance, the American Cancer Society that's hosting this. They mentioned of all the different subawards and different things they're doing to change, but I think if nothing else, they can really help you find some of those possible resources. So I really encourage you to work with kind of some of those people in your local, state, or regional area to find those types of solutions when it comes to grants and resources.
And I can add to that as well. As our clinic currently does not receive any kind of grant funding, I don't have much information as far as seeking or finding grant opportunities, but we do utilize our nursing staff and ancillary staff to increase our screening rates in order to provide patients with opportunities to get screened and increase it.
Thank you, Jessica. We have a question from Carol Wenzel, and we will be able to share the PowerPoint within the next, within coming days, within the next week. It will be available, and we will share that with you. Also, Ann Graham had a question about dealing with healthcare provider turnover that happens within our tribal health system. It is another common challenge to our small American Indian health system. Does anybody feel comfortable responding to that? Jessica, Richard?
I can say that that's fortunately not something that we have had to experience. We don't typically have a high turnover here at our clinic.
This is Richard. I guess, especially working with so many different facilities, I guess there's always different challenges, but I would say, when it comes to recruitment and retainment, there just could be possible challenges, and that's why, it's really ideal to start looking at elements of cross-training or especially empowering some of those different groups I kind of mentioned, like community health workers or public health nursing, because, in our area, we don't really have a lot of the capacity to do so much around sigmoidoscopies and colonoscopies. Hector's probably one of the few people out there really doing a lot of that great work, as well as in the Turtle Mountain community, and Rosebud's also looking at growing that capacity. But for the most part, when it comes to stool tests, I think of these individuals because they're the people that know everybody and will go knocking on door to door. So I think in a lot of ways, building your capacity around these groups and individuals and your community champions is ultimately what could lead to great success even outside of the clinic. So that's why I talk about that community clinical linkage being so important.
Thank you so much, Richard. Well, the questions are rolling in, of course, just as we're running out of time. While we didn't get to answer all of your questions, we will address the remaining questions in a follow-up email. As we leave today, I'd like to share a huge thank you to our speakers for generously sharing their time and expertise today. We'd like to really thank you, the individuals and organizations that participated in the CRC Summit and contributed to the post-meeting report, and to the many partners that are working to address cancer-related disparities among Native populations. And finally, a thank you to the CDC for providing the funding to make this webinar possible. I'd also like to give a special shout out to Emily, who has been amazing in helping to arrange this webinar and so much of this work that is happening to support increased CRC screening efforts in American Indian Alaska Native populations. Thank you, thank you. And please check the NCCRT.org and connect with us on social media to find more information about upcoming roundtable webinars and other news. For more information on today's webinar, please email nccrt@cancer.org, and you'll receive a follow-up email with a link to the handbook and the webinar replay. So again, thank you all for joining us today, and I hope you have a wonderful afternoon.